Hello，大家好。咁咧，呢條片咧係將會我攞嚟用作 preparation 係我嘅 OSCE 啦。咁我嚟緊係星期二，下個禮拜會考 OSCE 嚟嘅。咁今次嘅 OSCE 同平時我 Year 1、Year 2考開嗰啲有咩分別咧？咁有少少唔同嘅。咁大家見到啦，呢個就有個 brief 啦。You are a radiographer and have been asked to mentor a new first-year diagnostic radiography student。你一個放射師啦，你而家咧嘅工作就係要去指導一個 first year 嘅學生，要提供一個 tutorial 俾佢哋咧一個指導啦。咁係一個 pre-selected 嘅 scenario，咁即係咧到時老師就會有啲唔同嘅情景題啦，咁你可以選擇自己比較有信心嘅題目咁樣。你做咗嗰個情景題之後咧，你就開始去諗，你會有25分鐘去準備啦，去諗點樣去將呢樣嘢去教一個要運嘅學生咧。咁呢個就係今次嘅 OSCE 嘅特別之處啦。咁我哋唔使落手落腳做啦，我哋係只係憑講嘢啦，去教一個要運嘅學生仔。咁佢到時一個要運學生就乜嘢都唔識啦，咁我哋就要教佢咯喎。咁我都碌落去俾大家睇下啦。咁係有分唔同嘅部分嘅。咁第一部分咧就係 meeting and supporting student 啦。咁我哋一見到學生一嚟就唔係即刻講點樣做個 X-ray，係要首先介紹咗自己啦，要 build 一個 rapport 嘅同佢哋，即係話去建立咗個關係先。咁之後咧 introduction 完咗之後啦，就開始講下你嘅 content 就會係點樣做啦。你要 justify 個 referral form 啊，嗰啲等等嘅嘢，又講下個 pathology 啦，究竟你今次呢個 referral 要睇嘅嘢係乜嘢病痛咧？跟住嗰啲 policies 咁嘅嘢啦，我哋係最複雜嗰啲嚟嘅。跟住仲有 debrief 啦，就通常係講翻一啲你自己剛才冇做到嘅嘢，咁就希望喺度爭取翻啲分數啦。咁我就會試下去嘗試做一次啦。咁我亦都設定咗條題目啦。咁你用 ChatGPT 就 generate 一啲嘅題目啦。咁我見到第二條咧就有啲有趣啦。咁我就決定緊第二條。咁係一個 pelvis 嘅 X-ray，個病人跌低咗，72歲。係啦，cannot weight bear Curie NOF。咁我都會解釋究竟係咩嚟嘅 NOF fracture。好啦，咁就開始啦。第一部分啦就 introduction 啦，咁我就會咁樣開頭嘅。Hi, my name is Jody. I'm one of the diagnostic radiographers at the department today. What's your name? And you're in your first year? Lovely. So it's nice to meet you. So first of all, I would like you welcome you to the team and your first year placement. So I want to check in how you're finding placement so far. Okay, so thank you for sharing that. I completely understand why you feel that way and I appreciate your honesty. So just let you know, you're not expected to know everything at this stage. So my role here is to guide you, help you build confidence and make sure you feel supported throughout your learning journey. So let me just give you a brief induction on what you're going to expect during placement. So you need to follow your department rota for your working hours. So for example, you're working in X-ray this week from Monday to Friday, 9 to 5. So make sure that you arrive 15 minutes early before 9 so that you have time to get changed into your uniform. And then you get someone to sign you in. So it's better to be a band 6 radiographer to sign your attendance sheet and do the same after you finish at 5. So in between there would be a half an hour lunch break. So do let the radiographers know you went on your lunch and come back after half an hour to continue your placement. And if you're not feeling well that day, you know you're gonna be absent or you're running late, please let your practice educator know in advance. You can do that by emailing them. And then in terms of professionalism, so we work in line with HCPC standards, so that stands for Healthcare Profession Council, and the SOR standards, so that stands for the Society of Radiographers. So patient confidentiality, dignity, and respect is essential. And please wear your uniform all the time on site. They have to be neat and tidy. Always wear your name badge so that people know who you are, and then your TLD badge so that it can monitor the radiation dose you're receiving, and that is in compliance with IRR 17, so that is also known as the Ionizing Radiation Regulations 2017. And then in terms of safety is also a priority, so if you are uncertain about certain procedures and you're not too familiar with a piece of equipment, please stop and ask us. And then be familiar with the manual handling protocols, the radiation protection protocols. They are also very important. And then in terms of learning expectations, again, we're not expecting you to know everything at this stage. So by observing, asking questions, and then gradually participating is appropriate for a first-year student. Then I'll talk about the challenges or you might face during placement. So it's completely normal to have these because you're just starting your placement. So you might find yourself nervous when interacting with patients, or you are uncertain about the procedures, you find the department very busy or fast-paced and you're not used to that, or maybe you're thinking whether you fit within the team. So if you have any of the above, please talk to me. I will give you opportunities to observe and then try it yourself. I'll also explain the procedure step by step, and then just helping you to build that confidence along the way. And then we'll move on to talk about feedback. So it's a very important part of your training. So usually for me, I would talk about what you have done well or wrong, and then we'll focus on 1 to 2 areas to develop. And then we'll also set like achievable goals together. So for example, maybe you have done quite a lot of chest x-rays and you want to move on to try some like upper limbs or lower limbs. So please do let me know. Then I'll give you the opportunity to try them out. So that would be how I give feedbacks. And then just let you know, feedback isn't just about criticism, it's about how to help you grow and then build that confidence. So that's what you would expect from me. And your placement experience. If you got like any questions, you feel comfortable to let me know. 咁預備第一部分啦，我覺得係可以背咗佢嘅，即係你預先寫咗個 script，然後盡量背啦。咁我覺得自己仲要背到更多嘢，其實我已經背到大部分㗎啦，不過係有啲嘢都仲係爭啲啦，例如頭先我 mention 到嗰個key induction 嘅 information 係啦，提及到啦。Let me see， so challenges 嗰方面啦，我就應該要提及咧，要鼓勵個學生要 reflect on what have done well or wrong 啦，同埋要 check in regularly to make sure 個 student 係 coping academically and emotionally 啦。咁我想講呢個 tutorial 咧，唔係淨係單向嘅，係雙向嘅。嗰個學生同時都要提供佢嘅 reflection 俾你知啦，唔係淨係你去引導佢嘅。咁然後咧，頭先我講 constructive feedback 嗰度啦，我都漏咗少少嘢嘅，就係要 invite 個學生啦去講佢自己嘅 reflections，咁我就唔記得咗提呢級嘢啦。好啦，咁我哋去下一部分啦喎，咁就係講個 content of 個 tutorial 啦。Okay, so shall we begin the scenario together? So what clinical information and questions might the referral contain? So usually, in a referral form, we would have the patient's name, date of birth, address, NHS or hospital number. So these information are important because we use them to ID the patient when they come into the room, make sure that we're put on the right patient folder on Soliton. So it's a system that we use to put in the doses and also make sure that the images taken are sent to the correct folder on PACS. So PACS is a system where we store our images and send them to doctors. It's known as the Pictures Archiving Communication System. So therefore, patient details should be on the referral form. And then we'll take a look at the date of the referral form. So it should be up to date. So that should be within 4 to 6 weeks. So, and then we'll take a look at the terminology. So you can see question mark. So that stands for query. And then NOVF is neck of femur. So where's the femur? Yep, so it's in your leg. And hashtag would be a fracture. So that stands for fracture. That means the clinician is suspecting a fracture in a patient. So the query, neck of femur fracture. So that would be the terminology. The patient had a fall, RROM. So that stands for reduced range of movement. So the patient might have a fracture in them. That's why they're unable to move quite a lot. So that would be some terminologies that appears in a pelvic X-ray. And then let's see, would the examination answer the clinical question? So the referrer is asking for an AP pelvis. So just about to critique the referral form, how to make sure that it's justified. So before we move on to the clinical question examination, we have to make sure that the GMC number and the signature of the referrer are included. So GMC is usually for doctors, but not just doctors can do the referrals. Nurses and physiotherapists can also do the same, but they should be registered and they have received certain trainings to be qualified enough to do referrals. So that's why we have to have their GMC or NMC numbers on it and their signature as well. So these are some key elements that makes a referral form justified. And then besides that, we also need to check whether the examination answers the clinical question. So they're requesting for an AP pelvis and HBL as well. So the clinical question is a query neck of femur fracture. So yes, a pelvis X-ray does include the neck of femur in it. So the area of interest we're looking at does answer the clinical question. And then the clinical history also matches with the clinical question because the patient had a fall the other day. So a fall in older patients will lead to a fracture. And then for the patient presentation, so the patient might come in a trolley. That means like in a bed, or because it says here she's a 72-year-old female, so yes, so she is a very high chance that she might be in a trolley when she comes in. So how this differs to the standard views we usually do. So for AP views, for standard AP views, the patient maybe just come in and then you have them lie on the table and then you start to move the table and the detector and the tube, and then you get them to roll their feet inwards so that the trochanters are showing on the image. However, for a patient who is having a fracture on a trolley, it's quite hard to do that. So this is slightly different from the standard one. And usually, for a normal patient, we don't do HBL, but now we have to do an HBL, and I will later explain how we do that. We'll talk about the pathology then. So a neck of femur fracture。係啦，咁呢部分咧，頭先剛才講有25分鐘準備啦，咁呢25分鐘我相信啦，就攞嚟睇下究竟你嗰個 pathology 嘅詳細資料啦，嗰啲 positioning 嘅嘢啊，嗰啲 anatomy，你盡量就依個時間裏邊去揾晒佢啦。Okay, so what I found is that neck of femur fracture is a common injury sustained by an older patient because they have unsteadiness of the gait and reduced bone mineral density. So after a fall or a trauma case like a road traffic collision, it will lead to the neck of femur fracture. There are actually two types of the neck of femur fracture. One is known as the intracapsular, where the ball on top of the femur broke off at this junction with neck of upper thigh bone within hip joint. In this case, the surgeons have to reattach the ball, but usually replace with half a hip replacement. And so this is known as the hip hemiarthroplasty or total hip replacement. And the other kind is known as the extracapsular. So the fracture, the break is further down the femur, it's outside the hip joint and is fixed using a metal work. So registered radiographers are accountable to the IRMA 17, so that is the Ionizing Radiation Medical Exposure Regulations 2017. So this is a rule where we have to justify the referral form, make sure the doses are ALARP, so that stands for as low as reasonably practicable. Oh, and documentation of exposures as well. So under IRMA, we've got for duty holders, the employer, the referrer, the practitioner, and the operator. So they all have their defined responsibilities. So for the employer, it could be the hospital. They are the ones who set up the local rules. And then we got the referrer, where they have to provide sufficient information on the referral form. And then for the practitioner to justify the referral form before deciding whether to proceed with the examination. So here, if insufficient information are provided, we have to reach out to the referrer to clarify with them until we can proceed with the procedure. And then the operator would be the one who do the exposure, the one who presses the exposure button. So the practitioner and the operator can both be the radiographer. So then for professional standards and scope, registered radiographers can be accountable to the HCPC standards of proficiency and must practice within their competence. And the SOR guide provides guidance on scope of practice. And for student radiographers under IRMA, they can act as or assist the operator only under appropriate supervision. And then we'll talk about the local rules. So these are the ones that is set by the hospital, the employer, so they might include manual handling policies, infection control, contrast administration protocols, and escalation pathways to our patients. And then we got safeguarding. So if you notice that something is wrong, maybe a very young child came in for an x-ray, but it's a fracture and it shouldn't supposed to be there, so you might raise concerns about it. Or maybe a very old patient who's usually on the bed all the time, but they got like a fracture. So these are problems that we might have to notice, and these are known as safeguarding. And then data protection and confidentiality. And we also got something called incident reporting, so through a system called Datex. So for example, you're doing an x-ray for a wheelchair patient, they fell from the wheelchair during the x-ray, so that is something that we have to report as an incident. So how this imaging examination will help the patient's management. So if the x-ray does show a fracture on it, we have to red dot the image and let the doctors know. And then the patient will be after a report has been done, the patient might be sent for a surgical procedure to put in screws into it to make sure that the femur is stabilized and the fracture is no longer there. And then we'll talk about the relevant anatomy and physiology. So in a pelvic X-ray, we can see there's an iliac crest, and then the ilium in the inside, and then the two holes at the bottom would be called the obturator foramen. Then at the femur, we can see there's that capsule is known as the acetabulum, and then we can see the greater and lesser trochanter. The symphysis pubis is just in the middle, the ischium, tuberosity. So these are some anatomies that were shown on a pelvic X-ray. So then for qualified radiographers and student radiographers role, so qualified radiographers they work as a practitioner to justify something. They work as an operator to do the exposure, and they also have to optimize the technique and stuff. And then for student radiographers, they can assist with positioning and also assist with the exposure. However, they have to be supervised by a radiographer, and they cannot do X-rays independently. So how do we critique the images? So usually, we'll take a look at the sentence line around the pelvis. So if there's disruption, that means a loss of contour between normally continuous line from the medial edge of femoral neck and inferior edge of the superior pubic ramus, so that indicates a fracture. Or maybe the lesser trochanter is more prominent, so that shows an external rotation of the femur. We can use a 10-point checklist to critique the images. So the first one would be patient identification. Make sure that the patient's name, date of birth, hospital and NHS number are shown on the image. Then the second one would be the area of interest. So just I mentioned, we usually for the collimation, we want to be for the upper part of the collimation, it has to be 1.5 inches above the iliac crest. And then the mid-sagittal plane of the body is centered to midline of the grid. Distance between each ASIS is equal. And then for the third one would be the ledges and markers. Make sure that you put a marker onto it, indicate the left or the right. And if you're doing an HPL, do mention that it's an HPL, label that. And then for the fourth one would be the exposure factor. So it would be around 80 to 100 kVp, 80 to 320 MAS. The SID would be about 100 meters. So a grid can be used for, but if it's in a trolley, it might be hard to put in a grid in it. And then if we're doing the HBL, no grid is needed if we're doing the air gap technique. And yep, I forgot to mention about the positioning. So try to center the ray, like angle it perpendicular to the long axis of the neck of femur. The image receptor or bed can be adjusted 45 degrees to match the angle. So center midway between the ASIS and the pubic symphysis. So that would be the positioning. So for the HBL, it could be a bit challenging. So because you're placing the bed or the detector 45 degrees to it, there's an air gap between it. So the distance of the tube and the detector may be a bit further away than 100 meters. Then you try to, if you're x-raying the right hip, for example, you have to get the left leg away from the image so that it's not exposed as well. You can use some aids such as sponges, things to guide the positioning. And then we talk about the brightness of the image, whether you can see the bones and the soft tissues, and then sharpness, you can able to define between the soft tissues and the bony textures. And then for the contrast, you're able to see the bone trabeculates, for example. And then we'll talk about pathology. So if you see a fracture on an X-ray, there would be a break in the cortex, a loosened line across it. So that's how you see the pathology. And then what else? Need for action. So if there's a fracture I just mentioned, you have to red dot the image, let the doctors know, and the patient will be sent for a surgery. Oh yeah, so I forgot to mention about the pregnancy. Because this patient is 72 years old, she's outside the range of 12 to 55, so there is no need to check for pregnancy, even though that it's an area that is below the diaphragm, above the knees. So if the patient is within that range, you have to get them to do like a questionnaire to get their consent to proceed with the X-ray. If they are pregnant, you have to discuss alternative modalities with the doctors. 好啦，咁咧第二部分就做完啦。咁我就覺得，尤其是講 Radiographer 同一個學生之間有啲咩分別嗰部分咧，做得唔係咁好啦，可以再講得詳細啲啦。跟住係啦，Go through 10-point checklist 咧，我都應該要再仔細啲去揾啦。咁而家就講下個 debrief 啦。So why did I choose this scenario? Because I have done similar things before during placement. I've experienced with doing pelvis X-rays on older patients. You have to adapt the communication with them. So some of them might be having hearing problems, so you have to speak loudly to them and make sure that you give clear instructions on what you want them to do. Would you have done anything differently if you were to do this again? So for the tutorial, next time I would have given more opportunities for the students to ask questions or lead parts of the discussion. I will also incorporate more visual learning resources such as anatomical diagrams or sample images to support different learning styles, because some students can be a visual learner. And then I would reflect on whether I balance explanation with student-led exploration effectively and adjust the session to ensure that the student feel more engaged and empowered in their learning. And reflect on your own experiences. 咁我都想分享下啦，咁就係要用中文講咧。咁就係有一次我翻完嘢啦，跟住嗰日好想做 assessment，但可惜當日咧就冇一個合適嘅 Radiographer 嚟同我做啦。咁第二朝咧有一個可以 assess 我嘅入咗嚟間房，我就即刻同佢講可唔可以同我做 assessment 啊？咁咧，咁當時就有一個 case 啦，就係做個 middle finger 同 ring finger 嘅 case，我呢個好似喺上一條片都有講過嘅。咁之後咧，當個 patient 入咗嚟咧。我喺度咁講嘢啦，係咁即係做 positioning 啊，跟住準備 expose 之前咧，我係有望一望個放射師啦，希望佢可以話俾我聽下，我都問佢呢個 O 唔 OK 啊，想佢俾一個答案我，究竟我做得啱唔啱？咁但係咧，我想講佢全場咧，都係叉住隻手咧，完全一句嘢都唔講，一粒字都唔講，直至我做錯咗 expose 咗個 patient，佢先走過嚟話你係咪應該個 lateral？做到成個 oblique 咁係咪做錯咗咧？跟住其實經過呢次經歷咧，令我諗起當年同個 T 小姐，佢又係一粒聲都唔出，搞到即係變得個 patient 又辛苦啦，個 procedure 又耐啦，做得。咁經過呢啲經驗咧，我就覺得日後其實對住學生咧就唔應該難為佢哋，應該係佢哋做錯咗，我俾啲提示佢哋咯。或者即係提點佢哋應該點樣做啊，因為佢哋都係始終個學生嚟嘅，佢哋唔係長時間都喺度做呢啲咁嘅嘢，佢哋實習嘅時間又唔多，咁所以我覺得，如果我係一個 Radiographer，首先我會俾清晰嘅知識啦，會教佢哋點做咯，而唔係叉隻手乜嘢都唔講。So that would be how I prepare for my OSCE, so wish me good luck. So I hope that I pass the exam.